radiography, including color Doppler, imaging-guided procedures, CT and MRI. The area of interest and expertise are in the body, breast, oncology, CT, MRI, imaging. So we'd love to hear from him and have good lessons. Thank you very much. Please.
Hello. Yeah. Thank you for the introduction, Dr. Maki. And it's a pleasure to be here, and good morning, everyone. So let's start straight away. So the topic is basic reading of CT and MRI scans of abdomen. So I won't be going into too much details and covering everything, but I'll just tell you some salient important points from my point of view. So learning objectives of this presentation are to understand the basics of CT abdomen protocol. We'll see something about MRI abdomen sequences, and along the way we'll see some case examples including liver lesion characterization and role of MRI in Crohn's disease. So before we do any CT, we need to tailor the protocol of CT, and this depends on what are we looking for and which clinical question needs to be answered. So either we can do a non-contrast CT or we can do a CT with and without contrast. If we give contrast, then we need to decide which phase to scan in. If we give oral contrast, we need to decide whether it's going to be a positive contrast, negative contrast, or then rarely rectal contrast needs to be given. So if you have a person presenting from the emergency with pain, right lower quadrant, fever, vomiting, ultrasound done, it is it's inconclusive, and the ER doctor wants to rule out appendicitis. So in these cases, a non-contrast CT is good enough. So this is how appendicitis looks like on a CT scan. So that's the thick wall dilated appendix, and you see a lot of inflammatory stranding around the appendix. And that's again an enlarged appendix with an appendicolith. This is also a third image. This is appendicolith at the base of appendix and a hugely dilated appendix. So this all thing, what we see around the dilated appendix is termed as inflammatory stranding. And just to compare, this is how a normal appendix looks like. It's filled with contrast, and there's normal fat around the contrast. Just compare the fat here and the fat here. This is all termed as inflammatory stranding. So scans like this, non-contrast scans, are just good enough to diagnose appendicitis. So non-contrast scan can also see calcifications, urolithiasis, fat stranding, and then free fluid, pneumoperitoneum, and hematoma. For most of the cases, we do a detailed contrast scans, and then you have different protocols depending on what we are looking for, whether we are looking for liver lesion, pancreatic lesion, we are evaluating GI bleed, mesenteric ischemia, we are evaluating bowel obstruction. So these are all different protocols, but everything boils down to these three common sequences. You can do after doing a non-contrast, you need to do a late arterial, and you need to do a venous phase and a delayed phase scan. So most of our needs are sorted out with these three sequences. So let's see what these three sequences are. It's also called a triphasic scan or sometimes four-phase scan. So this is the non-contrast, and once we inject the contrast, we do a scan in the late arterial phase. So this is how you identify. You see contrast in the aorta and the portal vein. So this is very important. This is called the late arterial phase scan. Here you detect hypervascular lesions, and then you have a portal venous scan which starts 80 seconds after, in which phase the hepatic veins have also opacified, and you see a uniform contrast enhancement of the liver and spleen. So if there are any hypoenhancing lesions, you can pick them up. And this is a delayed phase scan, which is done after 5 minutes. So this is sometimes used to demonstrate filling in of hemangiomas or enhancement of fibrotic scars, things like that. So let's look a little bit more into the late arterial phase scan, as I think this is one of the most important phase. So in this phase, you see enhancement of hypervascular lesions, you see enhancement of stomach, bowel, pancreas, cortex of kidney. So this is how it looks like. This is the pancreas, which is enhancing really nicely, and you can pick up a small enhancing lesion in the pancreas, which are usually pancreatic neuroendocrine tumor if they enhance in the arterial phase scan. And on the bottom here is the pancreatic adenocarcinoma. Now in this phase, the pancreas enhancement is at its maximum. So this provides a relative contrast to differentiate between the pancreas and the mass. And this is a solid mass. It's a pancreatic adenocarcinoma. Also there's a metastasis here. And that's how the normal enhancement in the bowel looks like. So cases of GI bleed, bowel ischemia, they are picked up in these phases. So this is one of the very important phases. So this is a scan of a patient done in an early arterial and a late arterial phase. So in this, you're not able to appreciate the entire extent of the lesion as compared to the late arterial phase scan. So getting the timing of the scan is very much important. If you do it too early, you miss hypervascular lesions, and if you do even too late, then you may not have the entire extent of the lesions. So getting the timing right in the late arterial is of paramount importance. Then this is how a hepatic hemangioma looks like. On the non-contrast scan, it is hypodense. Then it shows a characteristic peripheral nodular enhancement in the late arterial or the early portal venous phase scan, and it fills in from periphery to center. And on the delayed phase scan, you see it completely filled in. So this is a very characteristic appearance of hemangioma, one of the most commonly detected lesions. So you don't have to do anything more about that. You can just leave them alone. And then this is how focal nodular hyperplasia looks like. This is an MRI, by the way, but the enhancement characteristics are the same. So what you see is there's a mass, and then there's a central scar in the mass, and in the early arterial phase it enhances. In the portal venous phase it retains contrast. It appears almost the same signal as the liver. It doesn't show any washout. And in the delayed phase you see is enhancement of the scar. So any mass with a central scar showing delayed enhancement, more likely it's going to be a focal nodular hyperplasia. When you are doing surveillance to detect HCC in cirrhotic liver, this is how it appears. So this is a background of a cirrhotic liver, and this you see a lesion here which is almost the same density as liver on plane. On the arterial phase scan, it shows a non-rim arterial phase enhancement. So in short, it's called non-rim AFI, or arterial phase enhancement. And then in the portal venous phase scan, it shows washout. The contrast just goes in and comes out. And then you see a enhancing peripheral capsule. So these are very characteristic features of hepatocellular carcinoma when you see it in the setting of cirrhosis of chronic liver disease. And this is the basis on which the whole LIRAD's scoring system is based. So this is a scoring system used for surveillance in chronic liver disease and cirrhosis to detect HCC. And this is a unified system so that everyone does it the same way. And it has to be just to be used in cases where there is cirrhosis or hepatitis B infection, or there is current or prior history of HCC, not to be used in normal people who don't have cirrhosis, or in cases of cirrhosis due to congenital hepatic fibrosis and due to vascular causes. So these are the cases in which you should not put LIRAD scoring. So like the features I was saying were so characteristic that if you see here, which is outlined in red, the arterial phase non-rim enhancement in a background of cirrhosis, if you see this and you have any of these features, that is enhancing capsule, non-peripheral washout, and threshold growth, the lesion straight away goes into LR4 and LR5 category. So that is the robustness of these criteria. These are some benign lesions, what we see in CT. So that is a hepatic cyst, imperceptible wall, hypodense. This is a hepatic abscess. It has got thick rag margins, and it has got a characteristic sign which is called a target sign. That means you see two layers of tissue. One is the inner enhancing layer, which is the granulation tissue, and the hypodense layer outside, which is the edema in the liver. So when you see this in the right clinical context, this is diagnostic of a hepatic abscess. The third one is characteristic of a hydatid cyst, where you see a lot of free-floating membranes or daughter cysts within. Then coming to administration of oral contrast during CT. Now, this depends on the local preferences, it depends on the referring doctor preferences, and sometimes local preferences in the department. But there are certain basic rules to it. And this is a good paper in the AJR recently published, which shows that when to use positive oral contrast. So positive oral contrast is just water mixed with some iodine. So in these cases, you need to use positive oral contrast. These are post-operative bowel leak or gastrointestinal fistula, where you need to demonstrate the contrast leaking out of the bowel, or suspected interloop abscess in oncologic staging, or in non-specific abdominal pain. And then in the middle are these are the circumstances in which to avoid the positive oral contrast: suspected mesenteric ischemia, intra-abdominal hemorrhage, CT angiographies, because if you give positive oral contrast, the contents in the lumen and any enhancement what you see just gets masked off. And when there is high risk of aspiration, better to avoid giving any oral contrast. And for hepatobiliary pancreatic indications, you can just do with neutral contrast, that is, give oral water to distend the bowel and scan. And areas of controversy where positive oral contrast is to be avoided could be non-traumatic abdominal pain, suspected appendicitis. You don't want to load these patients with too much of water. If there is appendicitis, they'll be straight away taken for surgery, so you don't want to load them with water. And Crohn's disease enhancement better appreciated if you give neutral contrast, and also penetrating abdominal trauma. So let's look at few case examples. Like this is a case of anastomotic leak after carcinoma colon surgery. So that is the anastomosis, and you see the contrast leaking out from the anastomotic site, outlining the bowel over here also. So in these cases, we give rectal contrast under low pressure, and we need to demonstrate this leak. And then this is another case of colocutaneous fistula. This was a case of complicated diverticulitis, developed anterior wall abscess, which was debrided, hence you see this defect. And on giving rectal contrast, you see this contrast leaking from the...
Let's just double change it.
Okay. Yeah, this is better. You can see the contrast leaking from the bowel into the anti-abdominal wall. So that is how you detect. Then interloop abscess, this is a case of complicated Crohn's with a large abscess here with air fluid levels. And you need to differentiate this from the bowel. So to have a little more confidence sometimes, so if you give oral contrast, you can well delineate that oral contrast has not reached here, so this is an abscess. So sometimes you can demonstrate these things in a much better way if you give oral contrast. And then coming to bowel ischemia, again late arterial phase is of great importance, and you give neutral contrast, that is water. So this is how the normal bowel wall enhancement looks like. So if you give positive contrast, enhancement of the bowel wall will be all lost. You won't be able to appreciate this nice enhancement in the bowel all along the way to rule out bowel ischemia. This is positive oral contrast. You won't get much information out of it. So give a neutral contrast or water, and this is how it appears. So this is the normal enhancing bowel. This is absolutely the ischemic bowel. No enhancement in the bowel wall at all. This is the same slide. You see the normal bowel enhancement and the ischemic bowel with a lot of fat standing here. And then you see the cause of the mesenteric ischemia here, the thrombus in the SMA, seen as a filling defect here and also here. So in these cases, when you are doing contrast, please do not give any positive oral contrast. Then GI bleed, it's CT complementary to both endoscopy, colonoscopy, and this is how it looks. Now, whenever you are seeing a case of GI bleed, just make sure you have both the non-contrast and the contrast phase together, and you can scroll them together to pick up any enhancement. So like this is a non-contrast. You see there's no enhancement here, and on the arterial phase you see this enhancing intense vascular lesion coming up, which is probably the cause of GI bleed. Another case, this is a non-contrast, you don't see any enhancement here. On the arterial phase you see an abnormal vessel in the ascending colon. So that is how you pick up
the causative factors for GI bleed. You can also pick up active bleeding, active contrast extravasation. So for this, the bleeding rate has to be more than 0.35 ml for it to be picked up on a CT scan. So this is a case of bleeding colonic diverticula. You do a late arterial phase scan, you see a little contrast blush here, and then you do a delayed phase scan where the contrast progressively accumulates here. So that indicates that the contrast here is leaking. So you need to see all the phases together to see if there is active contrast extravasation. Coming to some MRI abdomen protocol and sequences. So this is a big list of the sequences which we generally do, a lot of stuff there. But just to break down into basic sequences, these are the two important sequences which you should be looking at. So this is called a T2 sequence, these are the T1 sequence. Now how to identify them? Straight away look at the CSF, point your eyes towards the spinal canal, and if you see the CSF white, this is a T2. If you see the CSF black, this is T1 sequence. And this is a normal T1 sequence, this is T1 with fat suppression. What we do in fat suppression is we suppress all the fat so that we just see the pure T2 sequence and not the fat. So any inflammation or tumor, if you see, they will have little hyperintense or water content within them. So this is the phase you should be able to pick up most of the lesions when you do an MRI. So if you're busy in your clinical practice, you're doing your ward rounds, you don't have much time, you just want to have a quick look. So I suggest you find the sequence in your packs and scroll through this sequence, that is the T2FS. You'll be able to identify most of the things here which are reported. And then this is the T1 sequence. So this is the in-phase sequence, this is out-phase sequence. So here the CSF appears black. Now why we do in-phase, out-phase is to detect fat in a voxel. So if you have a fatty liver, the signal will drop. You compare the signal here of the liver and here. If you compare, the signal has dropped here. So this is fatty liver. So this is used to detect fatty liver, or sometimes, fat and lesions like hepatic adenoma have little bit fat. So if you have a lesion here with little bit signal drop, then it would indicate that it has some amount of fat, most likely hepatic adenoma or some adrenal adenomas also. So that is just one of the parameters we use for characterizing lesions. And the timing of scan remains much the same. You do arterial phase, portal venous, and the delayed phase scans. But with MRI, you have more liberty of running multiple phases here. Like you don't have to restrict to 3 phase because you're not giving any radiation to the patient. So you end up doing 4 or 5 phase to have the morphology of the lesion and flow of contrast dynamics better described. So that's the advantage of MRI. I think you have seen all this, your masters in picking up MRCP and all the findings of biliary tract. So what this sequence is, it's a basically highly weighted T2 sequence in which fluid appears bright. And then these are the 3 main types of the T2 sequence. They have all fancy names, you don't have to go into the details. So that's the MRCP sequence. It's basically highly weighted T2 sequence, and you can see the stones here very nicely. I won't go too much into detail of biliary tract pathologies. And so advantages of MRI over CT, there's no radiation involved, so it's good for pediatric patients, pregnant women, and following up cases of inflammatory bowel disease. You can also image patients who are allergic to CT contrast. Then certain things like cholelithiasis and all the biliary tract pathology is better seen on MRI rather than CT scan, and MRI provides a better superior contrast resolution. So we'll just have a brief look into the role of MRI in Crohn's disease. So the MRI angiography is basically done. You can identify the disease involvement, activity, extent. You can grade the severity of disease. You can look for complications. You can do multiple follow-ups to see how the patient is responding to the treatment. And then what we look for is we look for the bowel wall, we look for any penetrating disease, and then we look for any mesenteric findings. So just have a quick look at how we see all these things. So this is how the normal enterography image looks like. These are coronal sequences, and what we do is we give oral water mixed with some mannitol. So mannitol keeps the water inside and the water doesn't go out of the bowel very fast. And the patient drinks this solution quickly over a period of 30 minutes. We put them prone on a table, we give them some Buscopan, metoclopramide, so there is no peristalsis, he doesn't vomit, and then we do the scan. And so it appears like this is the T1, this is T2. So sometimes this contrast is also called a biphasic contrast because it has dissimilar appearance on two sequences. So that's how the bowel wall thickening looks like. In Crohn's, it's usually asymmetric. It involves the mesenteric border more than the other border, and you can see some saculations here. This is also the bowel wall thickening, how it appears, and then you can grade the bowel wall thickening as mild, moderate, severe. So anything more than 15 mm bowel wall thickening, you should start thinking of some other pathologies. You should rule out neoplastic pathologies. Rarely you find bowel wall thickness more than 15 mm in Crohn's. Then you have different patterns of bowel enhancement. You can have asymmetric mural pattern. One wall enhances more than the other. Then you can have a stratified bilamellar where only the inner wall enhances, the outer wall doesn't enhance. Then you can have the trilamellar enhancement if you have enhancement in the inner wall and the outer wall. The middle part is usually either filled with fat or it's filled with fibrous tissue, and if you see this kind of enhancement, it more indicates that it's a chronic stage. And enhancement also indicates disease activity. Then you look for the signal intensity within the bowel wall. So the way of looking at the signal intensity is you compare the signal in the bowel wall with the adjacent psoas muscle. So if you see here, this is much brighter than the muscle. So this is called T2 hyperintense. That is how to pick it up. You compare it with the adjacent psoas muscles or any other muscles here. And this is how you see the ulcerations. It's all serrated margins, irregular here, irregular here. So these are ulcerations. This is how you pick them up. And then this is known as Coombs signs or engorged vasa recta, where you see increased mesenteric vascularity in the segment of the inflamed bowel. So it appears like a comb. You know, these are the different teeth of the comb. This is not very specific for Crohn's. Any bowel inflammation which will cause increased vascularity, and you'll have a picture like this. But if you see this in Crohn's, it again suggests more active disease. So once you, and then stricture. So this is how a stricture appears. You see narrowing in the bowel, and you see a proximal bowel dilatation. Narrowing criteria is luminal diameter reduced by 50%, and proximal dilatation should be more than 3%. So if you have these two criteria, you can clearly define as a stricture. And sometimes you have probable stricture in which upstream dilatation is not there because sometimes there could be some fistula connecting, so there's not enough space to cause dilatation because the upper segment is getting decompressed. So then you can label it as a probable stricture when it is upstream dilatation is less than 3 centimeter. And here you can see a lot of fluid also in a case of Crohn's disease. So the point of identifying these criteria is once you have all these criteria, you can use one of the scoring systems like this, and you can score you can grade the disease severity. So you can see the thickness, fat signal, enhancement, pattern, length, Coombs sign, and then you can allot a score, and then you can grade it mild, moderate, severe, and then this is a good objective criteria to follow up these patients of Crohn's. So that's a good thing to know. Then appendicitis in pregnancy, we see these cases quite often. Usually we start with an ultrasound, but if ultrasound is inconclusive, patient has persistent pain, inflammatory markers are high, there is a concern that there is a strong suspicion of appendicitis. In these cases, you can go in for MRI. What we do is we do very limited sequences. The scan just takes 10-12 minutes, and we don't use intravenous contrast. And that is how the normal appendix looks like on an MRI. See the fat around it, absolutely bright, no inflammation there. And this is the fetus, and this is the coiled, thick-walled appendix here. And this is sometimes very useful in pregnancy because, you know, the ascending colon is all pulled and compressed towards one side. You have some difficulties of picking it up on ultrasound. So I think that's pretty much it for my presentation. So the take-home message CT and MRI scans need to be tailored based on clinical indication. Late arterial phase, very important to pick up lesions. We should know when to give positive and neutral oral contrast. We should have an understanding of basic MRI sequences to have a look at your scans. And then there are certain advantages of MRI over CT, like Crohn's disease follow-up or biliary tract pathology is better seen on MRI. Yeah, so that's it. Thank you.
Thank you very much. That was a wonderful talk, Salim.
Yes.
The two quick questions. We did not hear about the barium with the contrast, and we did not hear about the CT colonography. Can you comment?
Yeah, because the time I couldn't cover everything, yeah. So CT colonography can be done as a screening. So usually we give air in the colon and then do screening colonography. Yeah.
Okay. Second. Any comment, audience? With this wonderful talk, I don't think anybody can comment. Thank you very much. But we need our colleague to collaborate, see patient together with radiology. Thank you.
Thank you.
Yes, one comment is we see a lot of patients with SMA syndrome,
Yeah.
which is regarded as a rare disease. But now is in our radiology, we see many patients, especially those with high elasticity, thin, and we have been diagnosing SMA first by ultrasound suspicion, and then what do you think? Should we do MRI or CT scan?
Well, SMA syndrome, basically you need to demonstrate that the SMA angle is so narrow that it is cutting on the, compressing on the duodenum. So that needs to be demonstrated. Now, you can start with an ultrasound because that is easily available, and you can calculate the angle between the aorta and the SMA. So in SMA syndrome, it would be really narrow. So that is one way of doing it. Second is barium. Barium, I think, will give you a very nice picture. You do a barium in supine position, and where you will see a straight cutoff at the level of duodenum, which is caused by SMA, and then you make the patient a little bit prone, so SMA falls off anteriorly, and you can see the barium moving ahead. So I think these two can be done. Obviously, CT has its own advantages, but before going to CT, I think better to do ultrasound and the barium to look for that.
Any question from the floor?
Yes, sir.
No question?